Happy New Year. We are very excited to welcome everybody back for AYO Power. This is session number 5. We took a little bit of a break for December, so we are kicking off strong with several more sessions to wrap up this first round of our training. We are very excited for our speaker today and to get started on this topic. So I just wanted to mention few housekeeping. My name is Kayla. I'm the Senior Director at Elephants&Tea and partner with Doctors Mike Roth and Scott Merdler and the AYA Oncology Education Workforce to bring this amazing program to all of you. So I also want to thank AZI as our silver sponsor for just sponsoring and supporting this amazing initiative. You will see that we are being recorded. If you have not had a chance to check out our AYO Power website yet, you will find all of our previous sessions and recordings are there. Please check those out. That is something that is available to anybody. You can share those with your colleagues if people are not able to make the live sessions. All of that is there, including additional resources and lightning lessons. So a great hub of information and resources for everybody there. The chat and Q&A will be open for this session, so please make sure you are putting questions in there for our amazing speaker today. We love the dialogue that happens in these presentations, so this is a great opportunity to ask an expert your questions that you have on this topic. So with that, I will pass it over to Scott to introduce Karen.
Hi, everyone. Thank you, Kayla, and thank you, everyone, for joining us. And like Kayla said, Happy New Year, and welcome back to the second half of this first year of AYO Power. We're really excited for this super, super important session, something that we all know that probably most of us don't talk enough about, so we're going to talk about it today. So I'm very excited to introduce Dr. Karen Effinger, who is Associate Professor of Pediatrics at Emory University and the Medical Director of the Survivor Program at the Aflac Cancer and Blood Disorders Center at the Children's Healthcare of Atlanta. She's section leader for 3 of the Children's Oncology Group Long-Term Follow-Up Guidelines Committee task forces and institutional PI for a childhood cancer survivor study. Her research focuses on improving the health and quality of life of survivors with a particular focus on healthy lifestyle behaviors in AYA survivors. So she's the perfect person to talk to us today about substance use and abuse in our AYA oncology population. Thank you so much.
Thank you. Thanks, Scott, for that introduction and everybody for having me. I'm super excited to be here and really excited to talk about the subject because, as Scott mentioned, it is unfortunately an area that I think all of us can agree we do not necessarily do a great job of talking about, and we don't get a lot of training in general. So as Scott mentioned, I am Karen Effinger, and I'm an associate professor at Emory University and am now co-director of the Survivor program. As a disclosure, I do have some grant funding from Pfizer for some unrelated work that we're not going to be discussing today. And the majority of this talk will focus on AYA survivors. And it's not necessarily just because I'm a survivor physician, which I am, but really because there's not a lot of data about substance use and abuse in our on-therapy patients. So we will talk about it a little bit. But this is really an area, especially if there are junior people on this call looking for areas of research, this is an area that really needs more. So this is an outline of what we're going to be discussing today. So we'll start off with just talking about substance use and abuse in healthy adolescents and young adults, because I think we really need to realize what it's like in the United States these days. And then we'll move on to talk about the prevalence in our AYAs with a cancer history, the importance of addressing substance use in oncology. And really, I want to spend some time to focus on how do we discuss substance use with our patients? Because we all know it's important, but no one really tells us how to do that. So to start, let's talk about some substance use and abuse in our healthy adolescents and young adults. So this is data from a study called Monitoring the Future Survey, which was funded by the NIDA. And these are the most recent results, so from 2022. And it really looks at substance use and asks these questions in 8th graders, 12th graders, and then in a young adult population. And I think the main reason I really wanted to focus on this and show this data is because you can see by 12th grade, 27% of our 12th graders reported vaping nicotine in the past year, which is more than even our AYA or our young adult population. And you can see 12% of 8th graders. And so this is definitely something that if you talk to your patients enough, they will tell you, your young patients, that this is like happening in the bathrooms of our middle schools and high schools everywhere. Nearly a third of our 12th graders have used marijuana in the past year, which goes up to 43% of our young adults. Alcohol use is also very prevalent. So over half of our 12th graders and 83% of the young adults. And that includes binge drinking as well. So nearly a third of the young adults reported binge drinking. And then just to highlight that bottom line, because I thought it was so startling looking at it, but if you ask 8th graders about illicit drug use, and that's not including marijuana, 9% have tried different illicit drugs and 13% of our high school graduates. So just things to keep in mind, and such why it's so important to talk about these things, even with our younger patients. So I wanted to look at the US National Survey on Drug Use and Health as well, because that looks at substance use within the past month. So that's, not just a one-time trying of things, but usually if something's happened in the last month, it may be something that's more common for these kids and young adults. And what you can see is that the 18 to 25-year-olds really are the ones that have the highest prevalence of these behaviors. So nearly a third using tobacco, over a quarter using marijuana, again, 50% using alcohol, and nearly 30% reporting binge drinking. And when we look at other illicit substances, again, for the most part, that 18 to 25-year-old age range is the ones that have the highest use. And so marijuana being in 38%, looking down with prescription drug misuse in nearly 10%. And also to highlight, like in our really young patients, like the inhalants are something that the kind of more junior high to high school kids are at higher risk for. So just those are kind of the things to keep in mind as you're talking to your patients, depending on the age of your patients. So when we think about substance use disorders, that's obviously different than substance use. And a substance use disorder is characterized by impairment caused by recurrent use. So that could be health problems, disability, or failure to meet responsibility, like not being able to get to school or not being able to hold down a job. So in 2022, over nearly 12 million adolescents and young adults in the United States had a substance use disorder. And so that's an AYA definition for that study, and like the is 12 to 26 years of age. And nearly 700 had an opioid use disorder. And what we know is earlier age for substance use is associated with an increased risk of substance use disorders and mental health diagnoses. And we also know that co-occurring mental health disorders are associated with substance use disorders. And so with that, we think about ADHD, conduct disorders, and depression. So going back to the National Survey on Drug Use and Health and the prevalence of substance use disorders, this is using DSM criteria. And you can see that over a quarter of the young adults that are 18 to 25 years of age would meet the definition of a substance use disorder. And the highest disorder would be marijuana use disorders, followed very closely by the alcohol use disorders. And so again, these are really high numbers, and so really important areas for us to address. And I think if we were to think that our oncology patients are immune to this, we would be very, very naive. So speaking a little bit about the prevalence of substance use and abuse in our adolescents with a cancer history. So as I mentioned, there's very few studies on substance use for patients who are on therapy, especially in the AYA age range. So there was one study of 92 adolescents and young adults that were 12 to 25 years of age. And during their cancer therapy, they received survey twice that were 6 months apart. And it asked about the use in the past month. And what you can see is that about 10% of participants reported tobacco use. Nearly a quarter reported alcohol use. about 30% reported prescription drug use, and then other drugs were about a fourth of the patients. And there was another even smaller study that was about the same age range where they were again surveyed twice, this time 3 to 6 months apart, and asking about the past 2 weeks. And the numbers are about the same. So about a quarter of the participants reported illicit drug use, around 10% alcohol, tobacco. And then in this study, a little bit of a higher percentage, nearly 50% reported alcohol use. And so these are patients who are currently receiving chemotherapy. There was another study that looked at substance use in an outpatient palliative care visits for oncology patients, and they did urine drug tests as part of their very initial visit. So there were 963 adults, but only 8 or 16% were in the kind of young adult age range, so ages 18 to 39. And what their study found was that third, so 33% reported illicit drug use for the AYAs or had illicit drug use based on their urine testing, and about a fifth for adults. And the adolescents and young adults were more likely to test positive for marijuana and more likely to test positive for amphetamines. This was another study that I thought was really interesting. Again, just trying to find out like patients who are cancer patients and what do we think about for substance use. And this is looking at emergency room visits. So these were emergency room visits from 2009 to 2018, obtained from the nationwide emergency department sample. So there were over 54 million visits for patients that had a cancer diagnosis. So this is all based on coding. So hard to know if they have an active cancer diagnosis, if they're undergoing treatment, if they recently had it, but they were marked to have a cancer diagnosis. And close to 12 million, or 22%, were also associated with either a mental health or a substance use disorder. So the authors on this paper went through and said, okay, of the ones that have had a mental health or substance use disorder, what were the different disorders that these patients came to the emergency room with? And the number one thing was an alcohol-related disorder. It was followed by anxiety disorders and depressive disorders, and then opioid-related disorders. A little bit further down, you'll see stimulant-related disorders, miscellaneous substances and addictive disorders, and cannabis-related disorders. So these are people that ended up in the emergency room for one of these things. So I mentioned at the onset that substance use has been looked at more in the survivor population, and particularly in survivors of pediatric cancer. And so a lot of studies have looked at this kind of young adult population, and this is data from a meta-analysis that was published in 2016. And it looked at smoking, and through the meta-analysis, approximately 22% of adult survivors of pediatric cancer report smoking. And it was less likely than the siblings and less likely than their peers. With binge drinking, it was about 20%, which was less likely than their siblings, similar to their peers. And drug use was about 15%, which is again similar to their peers, but less likely than their peers, similar to their siblings. I think what's important to think about with a lot of these studies, and there have been many, many that have looked at, do survivors have similar rates of this, or are they a little bit less? And one thing to remember is a lot of these cohorts are self-selected. So they are, people are participating, people are filling in the survey. So that doesn't give us a great look at kind of like national data. And there's usually a selective population that tends to be more of a non-Hispanic white population. They tend to be more females. So this is a study that looked more at national data. This used data from the 2018 BRFSS survey and looked at marijuana use in adult cancer survivors. And the definition of a cancer survivor for most of this kind of national data is a question that basically asks, have you ever been diagnosed with cancer? And then have you been diagnosed within the past year? So this looked at last month marijuana use, and it was about 9% in the adults. But if you look at the age range for 18 to 34-year-olds, it was 26.8%. So again, what we have seen, so this is really more common in our young adult population. 50% of the respondents who used marijuana said that they were using it for medical reasons. And it was more associated with younger age, male sex, non-Hispanic, Black race and ethnicity, not married, and uninsured. I think what's also important that the study found was that the history of depression and a report of fair or poor health was really important factors that were more associated with marijuana use, as was current or former tobacco use and binge drinking. And so I think when we're thinking about our patients, it's really important to know that sometimes one substance can be related to others. And we really have to think about the mental health and kind of physical aspects for our patients. So this leads me into some of the studies that we've done at our institution. So this was a study of AYA survivor substance use using the 2015 to 2018 National Survey of Drug Use and Health. So kind of one of the original surveys that we were talking about. We looked at patients that were 12 to 34 years, and this was use within the past year. So there were 832 survivors and nearly 141,000 non-survivors. And the results I'm showing here, you can see that some of them are partially adjusted. And what that means is they were adjusted for demographics. So age, sex, race, income, insurance status, and survey year. And the fully adjusted models then took that and also added in reported health. So whether you feel like you're in good health or not, past year depression, and the number of non-medical conditions. What we found was that tobacco use, marijuana use, and other prescription drug use, non-opioid, were fairly similar between our comparisons and the survivors. So the survivors are the ones in blue, comparisons are the one in blue, and survivors are the one in green. And I think that's really important to see that really this is similar across our patients and their comparisons, meaning that our patients are just as likely as everyone else, and we know that this puts them at a little bit of a higher risk. When we look specifically at alcohol, in our models adjusted for sociodemographics, survivors were more likely to report alcohol use. This became no longer significant after adjusting for health, depression, a number of chronic conditions, basically saying that, that is part of the reason that's probably driving this difference. We also found that to be the case with illicit drug use and opioid use, as far as there being a difference. What was interesting with the opioid misuse, so this wasn't just use of prescriptions, but misuse of prescription opioids, was that even after we adjusted for reported health, depression, a number of chronic conditions, there was still a difference in our cancer patients. And so whether that be access or another reason, something that we really have to think through. When we looked at the rate of substance use disorders, there were similar rates in nicotine dependence, alcohol use disorders, and other psychotherapeutic drug use disorders. However, there were increased rates for marijuana use disorder, illicit drug use disorder, and prescription opioid use disorder. So our survivors were more likely to have these conditions based on this national survey. We then looked at the opioid misuse a little bit closer. And so this is just in participants who reported findings that were consistent with opioid misuse. So again, the non-cancer comparisons are in the light gray, the survivors are in the darker gray. And there was nothing significant, but if you kind of look at trends, the trends were that survivors reported using their opioids to relieve their physical pain, or because they were hooked or had to have the drug, but they were less likely to use it for feeling good or getting high, or to help with their feelings or tensions. What was significantly different was where survivors versus their peers were getting their prescriptions from. And so they were more likely to get it from one or multiple doctors, and less likely to get it from a friend or a relative. So following this study, our group performed another study. And this time we looked at market scan commercial insurance database. And we were looking at opioid prescriptions in that first year after completion of therapy. So this time I can tell you for sure, none of these patients were on therapy they had all completed their therapy within the past year. And we were really looking only at survivors of childhood cancer, so those who were diagnosed at less than 21 years of age. They completed their therapy. And in this, what I'm showing you now is for those that were aged 12 to 17 on the far left, and those that were aged 18 to 28 on the right-hand side. The survivors are in black and the controls are in gray. And what you can see were that our survivors in all age groups were more likely than their peers to have an opioid prescription. And that was true with every quarter out from their therapy. So even a year out, or that final quarter out from their treatment, they were still more likely to have an active opioid prescription. And when we looked at indicators for potential misuse, meaning high daily opioids, opioid overlaps, opioid or benzo overlaps, or dose escalation, what we saw were that survivors were more likely than their peers to report any indicator of misuse after we adjusted for sex, geographic region, and urban and rural differentiations. And that those remained similar across the ages and after adjusting for mental health disorders and painful conditions. When we looked at those that would have a diagnosis of a substance use disorder, so this is not specifically just focusing on opioids, but same with the same market scan data, we found that it was more common in survivors that were 18 to 28 years of age, so not in the 12 to 17-year age group, but in the older age group. And that was significant after we adjusted for demographics, but was no longer significant after adjusting for health status. I think one of the encouraging things that we found in our data, so this is going back to the National Survey for Drug Use and Health, was that survivors were more likely than their peers to report receiving treatment for their substance use disorders. So whether that be because they have more touch points with the medical system, but I think that is an encouraging thing that we do know that these patients are tending to get more treatment, even if they may have a higher risk for developing. So I want to talk a little bit now about the importance of addressing the substance use in oncology. And I always like to give a case presentation, and this takes me back. So this is a patient that I saw my very first year as an attending in Survivor Clinic. Fresh out of fellowship, and as I mentioned to others earlier, I really wish that this type of session, this AYAO Power existed when I was in training, because nobody talks about this. And so I saw this 23-year-old with neuroblastoma, and he was diagnosed at 2. He received chemotherapy, including some low-dose anthracyclines, and he had radiation to his abdomen. And I will say he had the worst case of scoliosis of anyone I have ever seen. I mean, his back looked kind of like an S, with very severe curvature, and he had very severe pain. And at his visit, he admitted to daily marijuana use. He was smoking at least 8 to 10 joints a day, and he was high in my visit, which made it a little bit easier to get him to be very open with his answers. He regularly used cocaine, and he had previously used PCP, but had stopped because he was tripping when a friend died, and so he felt like he should stop that. And in our visit, I talked to him a lot about his substance use and how I was afraid this may impact his health, and particularly his heart health. And unfortunately, he got an echo that day, and his ejection fraction had dropped from normal to 45%. And I think this just highlights again, his dose of anthracyclines was fairly small. Could this be therapy related? Possibly, but really, did the substances have some effect on it? Perhaps. So we know that when patients use substances on therapy, it's associated with decreased survival, reduced treatment adherence, increased health services utilization, other medical comorbidities. I think anecdotally, we know that it can interfere with the chemotherapy and radiation, make some side effects worse. There's a possibility of increasing toxicity, so breathing problems or liver problems, increased risk for infection, and also increased risk for mental health problems. Long-term, in our survivors, we know that their treatments put them at risk for different health disorders, and as do substances. So substances increase our risk for second malignancies, especially nicotine and alcohol. They increase the risk for heart disease. I have a lot of patients who come in and they're like, I absolutely don't smoke cigarettes, but of course I smoke marijuana. And there's more and more data coming out about the heart impact from regular marijuana use, the increased risk for lung disease, and then also increased risk for liver disease. So there are national screening recommendations. So the USPSTF recommends screening by asking questions about unhealthy drug use in all adults 18 years or older. And screening should be performed when services for accurate diagnosis and effective treatment and appropriate care can be offered or referred. The NCCN AYA oncology guidelines recommend screening for tobacco, alcohol, cannabis, and other substance use and abuse. For our younger patients, the AAP recommends universal screening of adolescents for tobacco, alcohol, and other drug use with a formal validated screening tool at every health supervision visit. And in my world, the Children's Oncology Group long-term follow-up guidelines recommend yearly assessment of risky behaviors, which are behaviors known to increase the likelihood of subsequent illness or injury. But how often are these patients really screened? There was a study, and again, this hasn't been looked at a lot, but there was a study of recently diagnosed cancer patients who smoke cigarettes. So the main study was a trial for patients who smoke cigarettes. So they're enrolled in a smoking cessation trial. And in that trial, the mean age was 59 years, so a little outside of the range that we're talking about today. But only 69% had assessment documented in the electronic health record, and most of that was alcohol. So 66% had alcohol documentation. The undocumented type was kind of a bucket term for drug use or illicit drug use. And that was in about a quarter, but only specifically talking about cannabis or opioids was in 2 to 3% when they went back and looked at the electronic health records. And of all those patients, only 4% had a plan or follow-up or said that they told patients to stop using the substances. There was a study of 2 outpatient clinics with adult survivors of childhood cancer in our AYA range. And again, 62% of the survivors had documented screening for alcohol use. They didn't specifically look at other drug use, but since these numbers are similar to the others, we could probably assume that that was much less. And then there was another study of AYA survivors, 216 survivors, and it showed that over 70% reported receiving no advice on smoking or alcohol consumption. And whether they truly received no advice is hard to know, but obviously it didn't stick with them if they did receive any. So part of the issue is that there are really no universal screeners that have been developed. And screening can happen many different ways. So verbally, electronically, written. And there was a good systematic review that came out in 2022 about different measurement tools. And really what it found was it depends on what you're trying to accomplish. If you're doing this for research or you're doing this for clinical practice. But I would say that what we really need are people to be champions at their institution and figure out ways to either have this as part of the electronic check-in. At some centers, nurses will ask adults about this when they are first going in. And we're going to talk about how we can address this with our patients. There are some examples of brief screeners. So there are different examples. I like this chart because it shows us which ones are for adolescents and which ones are for adults. One of the adolescents, the brief screener for alcohol, tobacco, and other drugs is 3 items, but if you answer positive to any, it can go up to 36. So I'm not going to go into detail on that. But a couple of the other ones that are very brief, the screening to brief intervention, or S2BI, really ask these first 3 questions: tobacco, alcohol, and marijuana, and whether you have, in the past year, if you've used them weekly, monthly, once or twice, or never. If you answer never, there are no further questions. If you answer positive to any of those, there are 4 additional questions that you can see. The TAP screener is for adults, and it stands for tobacco, alcohol, prescription, and other substances. And it is 4 questions. There are 5 here because The second question are for males, and the third question is for females based on the difference between what's considered binge drinking. And then if you respond positively to any of these, it expands with 9 more questions. And then even shorter, the NIDA quick screen is really just these 4 questions. Doing something is better than nothing. So any of these are good ideas for clinical use. So as I said, I wanted to spend the last part of our talk really discussing how to discuss substance use with patients. And so with smoking cessation, there's a evidence-based intervention for brief advice in primary care outpatient visits called the 5 A's. And it starts with asking. So identifying and documenting use for every patient at every visit, advising in a clear, personalized manner users to quit, assessing or asking about the willingness to quit, assisting if patients are willing to quit. So use counseling and pharmacotherapy to help them, and arranging, so following up afterwards, after the quit date. And while this is great in theory, it's also hard to put into practice. And so I wanted to talk a little bit about kind of my approach. And the first thing I can say is just to do it, or to start doing it if you aren't already. So incorporating this into your daily practice makes it much easier to do, and also to support your colleagues who are doing this. Once you get started, it makes it much less uncomfortable, and patients can tell when you're uncomfortable. So if you are, the more comfortable you get, the better it is for both you and for the patients, and you get the information that you need. I really think it's important to set the stage. So in a younger population, like in the pediatric center, kicking parents out is really important. For older people, you know, whether or not family members should stay, I would argue if it's parents, they should be kicked out. Sometimes I'll have a spouse that wants to stay, and usually what I will do is still ask them to step out just briefly to make sure that there's nothing that the patient wants to discuss without them present, mostly because if you ask them if you ask a young child in front of a parent, they will be afraid to say no sometimes. And the way I explain this to families is that adolescents and young adults need time to discuss topics with providers. So I usually ask at 13 with the parents there. By 14, I really kick parents out, whether or not they want to be kicked out for just a short period, and for sometimes like my whole physical exam, because it's a time that I can justify it to the parents not being there, and also give them some privacy to talk about things. I explain confidentiality. So there has been a statement by the AMA, the AAP, the American College of Obstetricians and Gynecologists, the American Academy of Family Physicians, Society for Adolescent Health and Medicine, that informed consent in this age group, and confidentiality is very important. It's important that this is a really non-judgmental space. I tell patients I want them to be honest with me, and that like they're not going to surprise me, and that I'm not going to judge them, but I'm trying to ask these questions because of their health. And I always ask first if they have any questions without their parents or family there, to kind of ease into things. I think it's really important to be relaxed. I tell them these are questions I ask everyone. And I ask them about their activities and their peers. So especially younger patients, sometimes it's easier to say like, hey, are any of your friends doing these things? Oh, okay, well, what about you? It's really important to use common terms and not medical jargon, and to explain why you're asking these questions. Again, like you're just really doing this to make sure that they're staying healthy, because that's your job. It's always important to be prepared for responses. So I tell people that they won't surprise me, and sometimes they do, but it's really important not to show that surprise. And I also say, like, know the lingo or fake it. So these are some different terms, like hillbilly heroin for Percocet. Purple drink has come up several times in my clinic. I will never forget the first time a patient told me that they were using dabs for marijuana, and I did not know what that was. And I walked out of the room, and I had a trainee with me, and they were like, "What's a dab?" I was like, "I don't know, but I'm going to Google it when I get out of the room." And it's always important to be ready with more questions. I say, don't be afraid to ask people if they seem like they're holding back. You can do it in a very kind and relaxed way, but you know, hey, I really feel like there's something, like, are you sure that's really what you're saying? Like, it seems like you're not there's something else you want to tell me. And these are just some simple ways to ask the questions. I'll say, do you smoke or vape? Do other people around you? If they say yes, nicotine, marijuana, both. Okay, well, how do you smoke it? Blunts, bowls, bongs, how often? And when you ask that question, you always have to be ready with what does not often mean to you. For some people, not often is twice a day. For some people, not often is twice a year. How much do you smoke on a typical day or at a typical time? And when they say not much, you say, okay, what does not much mean? Like 1 or 2 joints, 8 to 10 joints. Because again, everybody's has a different scale. It's really important too to have a plan for responses. And so while we're talking more about AYAs, the American Academy of Pediatrics really came up with a nice document to walk people through this. So I wanted to quickly go through that as well. So when a patient reports abstinence, so not using different substances, it's really important to give positive reinforcement. Explain why it's even more important for cancer patients or survivors to avoid the substances, and also develop a plan, especially for those younger patients, for when they are pressured, or if you know that their friends are doing it, what is that, how do they say no? It's important to kind of talk through. If patients report use without a disorder, so that's really limited use, it's usually socially and does not include problems, the important things are to advise them to stop, and also to discuss the harms associated with use, especially in light of their current or prior cancer treatment. With those with moderate, mild to moderate substance use disorders, so those are the patients that are using in high-risk situations or for emotional regulation, or that could be associated with a problem. It's really important to be clear and brief with your advice to quit, discuss the harms associated with it, negotiate behavior change, consider a mental health referral if needed. I have a lot of discussions about when patients tell me that they need it to sleep or with anxiety, how can we better treat that in a more healthy way? And consider a referral to substance use disorder treatment or breaking the confidentiality. Obviously, you would tell a patient first, but I think that's really important if it's needed to do. And for those with severe substance use disorders, so that's loss of control, compulsive drug use, meeting greater than 6 of the 11 criteria, everything that we talked about for the mild, but really making sure that you're referring to appropriate level of care. So I want to make sure we have plenty of time for questions. I have a couple of take-home points. I really want to make sure to hit home that our AYAs with cancer do use substances during treatment and in survivorship. And that substance use and misuse has more consequences in our AYAs with a cancer history. So our substance use should be addressed routinely by oncologists and our survivor providers. And just as a reminder, how to do this, just do it, incorporate it into your routine visits, set the stage where there's confidentiality, make sure you relax and normalize the discussion, and be prepared. So don't show surprise, ask your questions, and make sure you have a plan for any response. And with that, I would like to thank the organizers, thank all of you who have joined us, thank my team who's worked on this type of work with me. My contact information is all there as well, but I will stop sharing and see what questions and what kind of discussion we can have.
Thank you so much. That was a really informative and important talk and topic, and just trying to get us started to, like you said, to start asking the questions, which is really just the most important thing to really start the conversations. We did have a few questions in the chat, so I can start with that. One was from earlier on in your presentation, and it was about, did the amphetamine use account for people who may have tested positive due to ADHD medication use, or was this solely for illicit use?
Yeah, good question. So I don't know exactly where it was, for the drug screen study, I actually don't know the answer to that. It's something that I always think about, but for the survey, the national survey-based questions, it specifically asked about illicit use and not use for a medical purpose.
And then the next question was, did you perform subset analyses on cannabis use in states with versus without cannabis legalization?
So for our study, we did not. There has been I'm trying to think if it was the study that I presented that was somebody else's work, or there have been a couple of other studies that have looked at cannabis use in different regions based on legalization. And basically what the results have shown is what we could probably imagine them to be. There tends to be higher use in states where it is legal recreationally. But in all of the studies that I've seen, it tends to still be that like the survivors tend to have a little bit of a higher use than their peers if you're looking at national data.
And one question that I had that I'll throw in here, kind of piggybacking on that, when you were talking about, when someone responds that they use it sort of socially, or if they do respond that they use it for medical reasons, kind of what are your responses for that from the medical kind of, if they have a prescription or a card or, medical marijuana responses, and how to continue that conversation with them?
Yeah, I think it's really, I think it's an area that we're all trying to learn more about, right? I think, that we all know that every medication that we take, whether it be, they all have side effects. And I think what we're learning a little bit more is that there are some side effects for using marijuana and like some heart side effects. And so I think that becomes more of a discussion about risk versus benefit. One thing that I talk to my patients a lot about is like the actual smoking of the marijuana, like versus somebody who's using THC oil, because there's a lot of, I mean, even if it's medical marijuana, there are impurities. We know that smoke impacts the lungs. And so I tend to really drive home that point, that we want to make sure that we're keeping your body as healthy as we can, and that if you're going to use things, that you use them in a safe way. There are also other ways that we can address some of their reasoning for needing the medical marijuana too. I think we are trying to look more at different methods for pain reduction that aren't substance related. I mean, even having to, use gabapentin and stuff is not fun long term. But I think that one thing that we as kind of a society and a group need to do is really look at mental health and look at pain and how we can address that better in our patients during treatment, but also when they have finished.
Yeah. So follow-up questions that just came in. Given the increased number of AYAs using substances for pain compared to the general population, are we under-treating or underestimating long-term pain in AYA cancer survivors?
Yeah, I think that's a great question. And one thing that when we've done some of our opioid work, there's actually, I didn't show the data, but there's been a decrease in opioid prescriptions after kind of the newer legislation came in, when you have to like go through the system and look. And I work very closely with one of my palliative care colleagues. And I think one thing that she always drives home is we need to make sure that we're treating pain appropriately and not under treating people's pain, causing them to have these issues long-term versus, having them then move towards other substances or misusing their prescriptions to address their pain. So I do think that in general, we don't address pain very well. I know in practice, and when I see people, there have been patients who've seen some of my colleagues, for a very long time, and their pain has never been addressed. And I do think that we need to get better at addressing pain in order to prevent some of the substance use that we see.
Yeah, definitely. And then there was a question, although I think that you answered this later on during your talk, about specific language to use on surveys to ask patients and differentiating between marijuana, illicit drugs, opioids.
Yeah, I think that, for my, I think that it would be great if we all adopted better screeners, and there are those screeners that we looked at, but that will then make it easier across providers if people see more than one provider, that, we're all doing standard things. But for ourselves, like when you're actually talking to patients, because, sometimes people don't really tell the truth on screeners as well. I think I usually try to I kind of start at the top. I usually start with smoking or vaping, and then what products you're smoking or vaping. I move to alcohol. If they haven't endorsed specifically marijuana yet, I then go there, and then I kind of talk about other substances. And I usually like ask that lifetime type of question. And that's usually when I get people that are like, not really. And I'm like, tell me more about that, because not really is not really the answer for that kind of question.
A question in the chat was, how do we counter physicians who tell patients, one, that marijuana reduces opioid use and abuse, and two, can help prevent cancer recurrence?
Those are good questions. So I've actually not had a colleague that has told a patient about the cancer recurrence piece. I have had patients ask me about that, and to my knowledge, I have not seen studies that have shown that that has actually been replicated in our patient population. As far as decreasing opioid pain use, I think there are many ways to decrease opioid pain use that are perhaps not as toxic to our bodies. And I think one of the things that I have started talking more about is some of the newer data that has been coming out about the long-term cardiac effects of continued marijuana use, as well as the long-term neurocognitive effects, and especially in patients who are receiving other treatments that may be cardiotoxic and neurotoxic. I think that is something that we can talk to people about, because we know that there's data that have shown that kind of long-term use is not good for us, and that people who have undertreated pain or who have undertreated mental health disorders are at risk for developing a marijuana use disorder.
And then there was a comment, I think, responding to the previous question. We used to think that cancer survivors were using substances because of a belief of invincibility or wanting to live their life. But it seems more recent research has supported a different hypothesis, that substance abuse may be a form of coping. Less effective, healthy coping maybe, but still coping nonetheless.
Yeah, that's a good point. So I think that there's still, we don't really know, right? Like, and for every patient, it's a little bit different. I still meet the survivors who are like, I am living my life, and they use substances and they use them in that context. We also have many survivors who do use it as a form of coping. And so I think what's important, and we will never know fully for each patient individually, but it's really important to make sure that we're addressing it, to see where our patients are, and to make sure that then once we've been told, it's not just, okay, great, see you at your next visit. I mentioned and talking about this at every visit, and I think it's a little bit, in my world, when I see a patient once a year, it makes sense. You really need to do it at every visit. When you're in acute oncology, obviously every visit might be once a week, and so it may be too much. But what I do see happen frequently is like people who get used to this, like they'll do it once and then forget about it for a long time. And like there's plenty of data for other high-risk behaviors that patients initiated during treatment. And so there's nothing that we shouldn't be under the like falsity that like a patient's not going to suddenly start smoking or suddenly start drinking while they're getting treatment. Like patients definitely do that. There's not data to support that, but I can tell you it happens. And so we need to just make sure, once a month at some frequency that makes sense, we're continuing to circle back with patients and address these things.
All right, I think those are all the questions and comments that I saw in the Q&A and in the chat. Unless there was any other burning questions or thoughts. I don't think so. All right. Well, thank you very much. I'm going to turn this back to Kayla just for some closing comments.
Perfect. Yes, thank you so much. Thank you, Karen, for that amazing presentation. I feel like I learned so much and a lot of practical things that can be put into place today. So I think that's one of the major objectives of AYO Power is to give those nuggets and those keys that individuals can start using right away. So thank you for that. This will be recorded, as you've seen. So the recording and all of the additional resources will be coming out in an email. So make sure that you are signed up or subscribed to the Power emails to get notifications about all of that information. There is also a post survey link that will be dropped in the chat if Lisa hasn't done that already for us, but please fill that out. We absolutely use that information. We are already hard at work trying to figure out how to continue Power and grow it and what this is going to look like in the next chapter. So your feedback will absolutely play into that as well. Our next session is going to be on February 28th. Also at 12 p.m. Eastern, Dr. Jennifer Mack will be presenting on ethics in AYO care and end-of-life care. So very excited about that session next month, and we hope that you will join us for that as well. If you have any questions at all, please feel free to reach out to any of us on the team, but we will see you next month. Thank you so much to both of you.